Welcome back to the Great Adventure, Pediatric Pulmonary Physiology. This is the third presentation in the series. We're dealing with gas exchange and VQ Part 2. So this is the Great Adventure, Pediatric Pulmonary Physiology. And here is our series. We're on the third presentation. And we want you to approach this like a kid in a candy shop. So recall from last time, we talked about the basics of gas exchange, that alveolar O2 and PO2 and PCO2 are determined by the ventilation perfusion ratio, or VQ. The normal VQ ratio of 1 gives us a P alveolar O2 of 100 and a P alveolar CO2 of 40. For VQ greater than 1, oxygen is higher than normal and CO2 is lower than normal. For VQ less than 1, oxygen is lower than normal and CO2 is higher than normal. However, the alveolar air equation, which we also talked about, calculates P alveolar O2 assuming a uniform distribution of ventilation. Similarly, calculation of a P alveolar CO2 by VQ assumes a uniform distribution of ventilation. But nobody's lungs have a completely uniform distribution of ventilation. So how do regional differences in gas exchange affect arterial blood gases? P alveolar O2 and P alveolar CO2 are the average P end capillary O2 and P end capillary CO2 from many lung units with many different VQ ratios. The AO2 gradient, which is P alveolar O2 minus P arterial O2, sorry for the typo, is normal with a uniform process, but is increased with non-uniform distribution of ventilation, and especially with a right to left shunt. So how do regional differences in VQ affect P arterial O2 and P arterial CO2? So these are the things we're going to consider today. Regionally decreased VQ, right to left shunts, wasted ventilation. For fun, the regional VQ profiles in chronic obstructive pulmonary disease, and finally, hypoxia and hypercapnia. So regionally decreased VQ. We used this example last time. Let me just remind you. So here we have, along with half the ventilation in one lung as the other. If this were a uniformly decreased process, all right, we'd have a total of 3.75 liters per minute ventilation, 2.5 on one side and 1.25 on the other, and a total of 5, which would give us a VQ ratio of 0.75. If we did the calculations, that would give us a PCO2 of 53 and an alveolar PO2 by the alveolar air equation of 84. However, it's not uniform. So here we have ventilation of 2.5 over 2.5. We know this is a VQ ratio of 1, and we know what the PO2 and PCO2s are there. Here we have a ventilation of 1.25 liters per minute over a perfusion of 2.5. That's a VQ ratio of 1/2. So PCO2 in mixed venous coming in is 46, leaving this is 80. Over here we have a PCO2 of 40. The mean is 60, so the PCO2 would be 60. Here saturation is 100. Here a PO2 of 48 gives us a saturation of 80. That gives us a mean saturation of 90. And if we look at the oxyhemoglobin association curve, that's a PO2 of 60. Note the AO2 gradient is elevated. When we saw the uniformly decreased VQ, we got a PCO2 of 53 and a PO2 of 84. But when we have one lung that's relatively normal, but another area that is significantly decreased, the PCO2 is actually worse and the oxygen is actually worse, and the AO2 gradient is actually increased. So regional differences in VQ can sometimes result in even worse gas exchange. Or like that another way, visually, if this is the uniformly decreased VQ situation, so O2 is down, CO2 is a little bit up. In the non-uniform case, these are normal, but this is significantly more impacted. And so what we get here in arterial blood is significantly worse than in the uniform situation. Regionally decreased VQ, non-uniform distribution of ventilation and uniform perfusion gives us elevated PCO2, decreased PO2, elevated AO2 gradient, even when compared with uniformly decreased VQ. All right, so what if we try to correct this? So this lung ventilation is decreased. So we try to correct this by increasing in this lung, right? So we're going to increase ventilation here. We still have a VQ ratio of 0.5, but we have a VQ ratio here of 1.5. So if this were a uniform process, it turns out that ventilation would equal perfusion, and we'd have a VQ ratio of 1, and we know this gives us a PCO2 of 40 and a PO2 of 100. What about in the non-uniform situation? From the last example, we calculated VQ ratio, the data for VQ ratio of 0.5. That's going to give us a PCO2 of 80, PO2 of 50. All right, so that means we've got a PO2 of 80 coming here and a SAT of 80. Over here, VQ ratio 1.5 gives us a PCO2 of 27 and a PO2 of 116. I've done the calculations for you. And so here we have PCO2 of 27, averaging with a PCO2 of 80, that gives us 54. We have a SAT of 100, SAT of 80, gives us a mean SAT of 90, that gives us a PO2 of 60. In the uniform situation, we had essentially normal gas exchange. But now with the non-uniform, regionally decreased VQ, PCO2 is increased, PO2 is decreased, and the O2 saturation, the AAO2 difference is 40, quite elevated, indicating non-uniform distribution of ventilation. In the uniformly decreased VQ situation, we had this. In the regional decreased situation, we had this. We had a much greater abnormality than in the uniform situation. Compensating increased VQ in a normal region of lung cannot correct for regional hypoxia. So one cannot correct regional hypoxia by increasing VQ in another lung region. And the reason is that the oxyhemoglobin dissociation curve is nonlinear, and maximal O2 saturation was already achieved with a VQ ratio of 1. Increased VQ does not increase saturation further. You can't go higher than 100%. The AAO2 gradient remains increased, and because of this, arterial PO2 is the most sensitive indicator of the presence of lung disease. You can't compensate for it. So you've got an area of local regional VQ, which is causing hypoxia, and even if you increase ventilation in other parts of the lung, you don't compensate for that. Hypoxia still persists. This is just an example of a study of adolescents who had bronchiolitis in infancy. They were studied at about age 10, 11, when most of lung development is complete. And you can see that they did have some lung function abnormalities, but the most common one was a decreased arterial PO2 because it's the most sensitive index of the presence of lung disease, even mild lung disease. So let's go back to our original situation. Normal VQ here, VQ ratio of 0.5 here. We had a lot of problem with oxygen, so let's give supplemental oxygen. Let's see what happens. If this were a uniform process, okay, the overall VQ ratio would be 0.75. That would give us a PCO2 of 53. And because of the supplemental oxygen, a PO2 of 291. All right, how about this situation? So here's a VQ of 1. So we know the PCO2 is 40, but we're now breathing 50% oxygen. So alveolar O2 is markedly increased, okay? However, saturation is still only 100%. You can't get greater than 100%, all right? Over here, VQ ratio of half, we know PCO2 is 80. Again, because of the increased supplemental oxygen, P alveolar O2 is increased. And again, saturation is 100. So 40, the mean of 40 and 80 gives 60. That's no different than when we were breathing room air. But saturations of 100, this gives us a mean of about 250 or so. All right. So clearly, supplemental oxygen improves arterial oxygenation, even in non-uniform decreases in ventilation and VQ. So again, here's the situation. Uniformly decreased PCO2, 53, 291. Regional decreased VQ, but with supplemental oxygen, CO2 is worse, and the PO2 is slightly worse. Again, AO2 gradient is elevated at 41. So uniformly decreased VQ, obviously oxygen is decreased, O2 slightly increased, And regional decreases, in this situation, this is normal, but here PCO2 is also elevated, and the RTO values are huge compared to the uniform situation. So for regional decreased VQ breathing supplemental oxygen at 50%, an increase in FiO2 can correct arterial PO2, but not increased PCO2. So PCO2 is not affected by increased FiO2. P arterial O2 is improved by FiO2. The AO2 gradient is increased even more. Thus, one can correct regional hypoxia by increasing the FiO2. But the reason is that that increased FiO2 is also going to the decreased VQ region. So in terms of compensating for regionally decreased VQ, increased PCO2 due to regional decreased VQ can be compensated by increasing VQ in another region. Decreased P arterial O2 due to regional decreased VQ cannot be compensated by increasing VQ in another region, but it can be compensated by breathing an increased fraction of inspired oxygen or supplemental oxygen. Okay, probably the best way to correct non-uniform distribution would be if we could match with perfusion. So if we have a situation here, alveolar ventilation 3.75, if we could match that with a blood flow 3.75, with decreased ventilation here, if we could match that with a decreased blood flow of 1.25, then the situation we would get would be VQ ratios of 1 everywhere. And clearly we're going to improve oxygenation and CO2. And note that the AO2 gradient is low because the distribution of VQ is uniform. So by decreasing perfusion to areas of decreased ventilation, the lung compensates to correct hypoxia and hypercapnia. And the lung actually does this to some extent, which we'll talk about in a few presentations. The alveolar AAO2 gradient is low due to the normal VQ. All right, what about uniform distribution of ventilation, but non-uniform distribution of perfusion? All right, this is going to give us a low VQ here and a high VQ here. If this were a uniform process, the VQ would ultimately be 1, we'd get a PCO2 of 40 and a PaO2 of 100. So what actually happens? So we've got a VQ ratio here of 2.5, right? That gives us a PCO2 of 16, all right? PO2 of 130. Here we have a VQ of 0.625. That gives us a PCO2 of 63 and a PO2 of 71. 63 and 16 basically average, but remember there's 4 times as much blood coming here than here, so you get a PCO2 of 54. And a SAT of 92, again, 4 times as much blood coming here than here, SAT of 94, and that gives us a PO2 of 70. All right. So again, looking, regional decreased VQ, PCO2 is worse, oxygenation is worse, and we have an even higher AAO2 gradient. So uniformly decreased ventilation, you can see these are actually pretty good. But with regional decreases, that was uniform, with regional decreases, the oxygen is much lower and the PCO2 is higher. Gas exchange and regionally decreased VQ. Increased arterial CO2 due to regional decreased VQ can be compensated by increasing VQ in another region. However, decreased PO2 due to regional decreased VQ cannot be compensated by increasing VQ in another region. Decreased PO2 due to regional or uniform VQ can be compensated by breathing supplemental oxygen. But both decreased PO2 and increased PCO2 due to regional decreased VQ can be best compensated by decreasing perfusion to the area where ventilation is also decreased. We're not, unfortunately, able to do that in medicine, but that would be the ideal physiologic solution. Let's consider 2 extremes of gas exchange abnormalities. So right to left shunt is actually a VQ ratio of 0. We have areas of lung that are perfused but not ventilated, filled with water, pulmonary edema, infected material, whatever. Okay, so VQ ratio of 1, right to left shunt, meaning that blood travels from the right side of the heart to the left side of the heart without coming into contact with the gas exchange surface. So here we're going to have all of the ventilation now going to this side. So it's actually going to be a ratio of 2. There's no ventilation here, but there still is blood flow. So what do we get? So here we have a VQ ratio of 2. The PCO2 is 20. PaO2 is 125. So we're going to get these values coming into arterial blood. Over here, there's no gas exchange. So the arterial PCO2 is going to be mixed venous, 46. And the arterial PO2 is going to be mixed venous, 40. And saturation will be mixed venous, 75. PCO2 43 and 20 combined to a PCO2 of 33. Saturation of 75 and a saturation of 100 combined to a saturation of 88. We have elevated CO2, decreased O2, right? And the abnormal blood gas is decreased PCO2 in this case, because we were able to compensate. It's due to compensatory increased ventilation in the good lung, severely decreased PO2, and the AAO2 gradient is increased. All right, so what do you want to do? You got a patient with hypoxia, but the CO2 is normal, or in fact decreased. So you might use supplemental oxygen. You don't need to ventilate the patient. So let's, if a little is good, a lot is better, let's give this person 100% oxygen. All right, so now over here again we have no gas exchange, so PCO2 is going to be 46, PO2 is going to be 40, saturation is going to be 75. Over here we do have ventilation, PCO2 of 20 in this case. The mean of 46 and 25 is 33, which is the same as it was before. Oxygen is now much higher because of the supplemental oxygen, but the SAT is still only 100. So a SAT of 75 and a SAT of 100 give you a SAT of 88, which gives you a PO2 of 16. This is exactly the same as we saw in our previous example. A right to left shunt is a special case of VQ. In a right to left shunt, one cannot increase PO2 by increasing the FiO2. And the AO2 gradient increases even further with the increased FiO2. For right to left shunt, one cannot correct PO2 by increasing VQ in another lung region. One cannot correct decreased PO2 by increasing FiO2. Thus, a right to left shunt is a special case of decreased VQ because it does not respond to supplemental oxygen. We can calculate the shunt fraction. So what's given here is QS is the blood flow through the shunt. Q is the total blood flow, our cardiac output. CaO2 is content of arterial blood, content of pulmonary capillary blood, content of mixed venous blood, content of pulmonary capillary blood. So this equation gives us the right to left shunt. Let's just go through it. The O2 content of arterial blood is the amount of oxygen of blood that traversed the pulmonary capillaries plus the amount in shunted blood. The amount of oxygen is going to be Q, blood flow, times the content of oxygen. So this is the total O2 content, and it's going to be comprised of the content of blood that goes through the pulmonary capillaries and the content of blood that goes through the shunt. Now, pulmonary capillary blood equals total blood flow minus shunt blood flow. So we can basically reconfigure the equation as shown here. And again, as shown here, and I'm not going to go through the algebra with you, but basically we end up with this equation, that the arterial minus capillary O2 content, okay, so that's really the part that is basically being ventilated, okay, divided by the total amount of oxygen, which is the mixed venous O2 minus capillary O2. So this really is, this is the total amount involved in gas exchange. This really is only the amount that goes through the shunt. And so this gives us the shunt fraction, amount of blood flow going through the pulmonary shunt, uh, through the shunt versus the total amount of blood flow, shunt and pulmonary. Now, the problem is we can calculate everything in this equation except the content of capillary O2, right? This can be estimated using N capillary O2 if N capillary O2 is nearly equal to alveolar O2. And it is nearly equal when you breathe 100% oxygen. So what's shown here is the P alveolar O2 on 100% oxygen, P in capillary O2 on 100% oxygen, which is 99.9. The AO2 gradient here is negligible. So basically, you can in fact calculate this when you are breathing 100% oxygen if you use P alveolar O2 to get this value. Let's talk about wasted ventilation. This is the other extreme of gas exchange. So this is a case where there is ventilation that's not perfused. So remember, the total minute ventilation is composed of alveolar ventilation, which takes part in gas exchange, and wasted ventilation, that is, that ventilation that does not take part in gas exchange, which we refer to as wasted ventilation. We can actually have two types of respiratory dead space. One is so-called in parallel, meaning that some molecules go here and others in parallel go here. So this would be non-perfused alveoli. So that's respiratory dead space in parallel. In series is where the molecule goes through one and then the other, one after the other in series. And in this case, conducting airways are basically respiratory dead space in series. Remember, definition of conducting airways, that gas exchange does not occur in conducting airways. So let's look at these. So for wasted ventilation in parallel, here we have a lung that is ventilated and perfused. Here we have a lung that is ventilated and not perfused. Now in this case, note that all the perfusion goes to this lung. So it's going to give us a VQ ratio of 1/2. All right. So here's what we get. Here in the alveolus, we have a PO2 of 150 and a PCO2 of 0, but none of that gets into the blood. Over here, we have VQ ratio of 1/2. So we have a PCO2 of 80, a PO2 of 50. And this is the only thing contributing to arterial blood gas. So basically, we get the same thing we got for a VQ ratio of 1/2, PCO2 of 80, PO2 of 50. All right. So the point here is that wasted ventilation in parallel has no effect on arterial blood gases. So the right lung, no blood flow, thus there's no mixing of blood from the right lung to that of the left lung. Wasted ventilation in parallel has no effect on arterial blood gases. And in this case, the hypoxia and hypercapnia are due to the decreased VQ in the perfused lung. It is not due to the wasted ventilation per se. The other type of wasted ventilation is in series. So in a normal individual at rest, let's say that somebody is breathing with a tidal volume of 450 mLs. The dead space is about 150. We talked about 2 mLs per kilo. So when you inspire, the first thing that enters the lung is what was sitting in your wasted ventilation. So you breathe that in, 300 mLs of fresh air comes in, and the last 150 remains in the conducting airways. So you get total tidal volume of 400, wasted ventilation 150, alveolar ventilation 300. Now, if you hypoventilate, if your tidal volume is only 300, then you're actually only exchanging 150 of alveolar ventilation on each breath. And in a very severe situation, if you have a tidal volume of 150, then you're actually only exchanging dead space. You've got no alveolar ventilation, and this would not be compatible with life. This can sometimes happen in the ICU if we put too much dead space on a ventilator, for example. Even though this tidal volume is normal at 450, if 300 mLs is dead space, only 150 is alveolar ventilation. Let's look at another situation. Let's imagine we have 3 patients, all of whom are breathing 8 liters per minute. Okay? So dead space is 150. So in this situation, we have somebody breathing 32 times a minute with a tidal volume of 250. That equals 8 liters per minute. what you can see is this person has to clear that wasted ventilation 32 times. So wasted ventilation is 4.8 liters. Alveolar ventilation is only 3.2 liters. This is rapid shallow breathing. Now we have someone doing a more normal pattern, 500 ml tidal volume, 16 times a minute. Okay, this person only has to clear this 150 16 times for 2.4 liters per minute of wasted ventilation and 5.6 liters per minute of alveolar ventilation. Now, if somebody has kind of an extreme pattern, breathes only 8 times a minute, but a tidal volume of 1 liter. All these still are 8 liters per minute ventilation. But in this case, he has to only clear this 150 8 times, which is 1.2 liters, and alveolar ventilation is 6.8. In all three cases, the patient is breathing the same total amount of ventilation, 8 liters per minute, right? But the pattern of breathing makes a difference about how much of that is wasted and how much of that is alveolar. And obviously, rapid shallow breathing is the most inefficient breathing pattern because it has the lowest alveolar ventilation. So just to summarize, there are two types of respiratory dead space: in parallel, which are non-perfused alveoli, and in series, one after the other, which are conducting airways. In parallel, wasted ventilation has no effect on P arterial or CO2 or O2. However, in series, dead space or wasted ventilation can decrease alveolar ventilation, which would decrease oxygen and increase PCO2. We can calculate wasted ventilation with what's called the Bohr equation, and we'll just derive it for you for a second here. The measure of CO2 production would be the fraction of exhaled, and this is mixed exhaled CO2, times minute ventilation. But all the CO2 comes from alveoli. So CO2 also is the fraction of alveolar CO2 times alveolar ventilation. So we can make these two equal, all right? We can change F fraction of CO2 to PCO2 by multiplying by barometric pressure minus water vapor pressure. So we get P exhaled CO2 times total minute ventilation equals P alveolar CO2 times alveolar ventilation. If we continue this particular equation here, all right, so we've basically made this equal. VA we know equals, just from this equation, FeCO2 over FaCO2, this is arterial in this case, or alveolar, right? Please note that this is fraction of exhaled CO2, not end-tidal CO2. It is mixed expired fraction of CO2. End-tidal CO2 would be FeTCO2. Right, so here we can calculate alveolar ventilation, and then note same thing for PO2 and PCO2. And the reason for that is that end-tidal CO2 is the highest CO2 that you achieve in exhalation. What we want is the average CO2, or the mixed expired value or average value. All right, so basically then we're back to getting this equation. VD equals VE minus VE times P exhaled CO2 over P alveolar CO2. Okay. And then we get this particular equation. So this is the Bohr equation. Partial pressure of alveolar CO2 minus exhaled CO2 over alveolar CO2. VDVT or VD over total ventilation. So the way we would use this, let's say for sake of argument, we get a situation here where half of the lungs were basically non-perfused alveoli. So our alveolar CO2 might be 40, but the mixed exhaled CO2 would be 20. 40 minus 20 over 40 equals 50%, meaning 50% wasted ventilation. Another example, if we had slightly less alveolar CO2, again 40, mixed expired CO2 30, 40 minus 30 over 40 is 25% wasted ventilation. So this can be fairly easily calculated. All right, for fun, let's just review a project I did for my MD thesis at UCSD. And we looked at regional VQ profiles in COPD patients. These are adults. This was the title, Regional Ventilation Perfusion Profiles of the Pink Puffer and Blue Bloater, a pathophysiologic basis for their divergent patterns of breathing. And my primary mentor here was Jerry Teasy, who was a faculty member at UCSD when I was a medical student. COPD is classically divided into those with chronic bronchitis, commonly known as blue bloaters, and those with primary emphysema, commonly known as pink puffers. The issue here is that there seems to be differences in their ventilatory responses. So is this differences in respiratory mechanics, or are these differences due to CO2 sensitivity? So the specific aims of the study was, is there a difference in the regional VQ profiles of patients with emphysema and chronic bronchitis? And can the regional VQ pattern be used to separate patients with emphysema from those with chronic bronchitis? So we had a group of emphysema patients and chronic bronchitis patients. Here was their minute ventilation for each group and their dead space, calculated by the Bohr equations we mentioned. As you can see, emphysema had higher total ventilation and a bit higher dead space than the chronic bronchitics. These are pulmonary functions. So FEV1 over FVC was quite low in the emphysema group, not quite so low in chronic bronchitis. MMEF, which we now call forced expiratory flow, between 25 and 75% of the forced vital capacity, really quite low for both groups. And airway resistance was pretty similar, actually, between the groups. We measured pulmonary compliance, and it was, as expected, closer to normal value here in emphysema. Well, it's elevated, I should say, sorry, in emphysema, decreased in chronic bronchitis. Coefficient of recoil, which is kind of the inverse, shows that there's less elastic recoil in the emphysema patients versus the chronic bronchitics. We measured VQ objectively, and so minute ventilation over pulmonary blood flow was higher in emphysema than chronic bronchitics. Alveolar ventilation over blood flow was also higher, and these were statistically different. We then measured, did ventilation and perfusion scanning using inhaled xenon and xenon injected, which is insoluble in water, so it comes out immediately when it comes into contact with an air interface. And then this was put into a computer program. And so what we had then was a map of the lungs with the distribution of ventilation, perfusion, and ventilation divided by perfusion to give VQ. So this is just kind of an example. This is a ventilation scan and a perfusion scan for the chronic bronchitics. And in fact, these were not uniform. So this represents areas of difference. In contrast, the ventilation and perfusion scans for the emphysemics were quite similar. And these are the profiles of the patients. So the red indicates the pink puffers. And you can see that as a group, what this is percent of the lung, okay, with different VQ ratios. And you can see that as a group, the pink puffers had a higher profile of VQ, regional VQ, than the chronic bronchitics. So the regional VQ profiles are different in emphysema and chronic bronchitis. The patient with emphysema has matched defects in ventilation and blood flow due to combined airway and parenchymal disease. The chronic bronchitic has greater mismatching of ventilation and perfusion due to the primacy of his airway disease. So we speculated that because the patient with emphysema has matched defects in ventilation and blood flow due to his combined airway and parenchymal disease, he can increase ventilation and improve gas exchange. However, because the chronic bronchitic has greater mismatching of ventilation and perfusion due to primacy of his airway disease, he cannot improve gas exchange by increasing ventilation. So let's just finish with textbook physiologic causes of hypoxia. So this is cyanosis. So the textbook causes of hypoxia are diffusion defects, hypoventilation, decreased VQ, either regional or uniform, and right to left shunt. Now, note that, remember, we talked about the fact there are no diffusion defects in animals or man that cause isolated hypoxia at rest. But at least theoretically, diffusion defects can cause hypoxia. For CO2, there are only two: hypoventilation, which is basically uniform decreased ventilation, and regional decreased VQ. Remember, in the right to left shunt, patients can compensate with good lung and their CO2 is so diffusible that no one has ever postulated a diffusion defect for CO2. Terminology: hypoventilation is decreased alveolar ventilation and increased PCO2. Hyperventilation is increased alveolar ventilation and decreased CO2. Increased ventilation without a decrease in PCO2 is hyperpnea, and it is distinguished from hyperventilation. And similarly, a decrease in ventilation with a normal PCO2 is hypopnea, which is different from hypoventilation. The basics of gas exchange: alveolar O2 and alveolar CO2 are determined by VQ. The normal situation, VQ of 1, gives us an alveolar PO2 of around 100, alveolar PCO2 of around 40. Increased VQ gives you increased oxygen and decreased CO2 relative to normal. Decreased VQ gives you decreased oxygen and increased CO2. VQ determines the arterial O2 and PCO2. Different VQ units contribute to P arterial O2 and CO2. Non-uniform distribution of ventilation often causes worse hypoxia and hypercapnia than uniformly decreased VQ. Blood from different VQ units combine to determine arterial PO2 and arterial PCO2. The AAO2 gradient, or difference between alveolar and arterial O2, helps determine the physiologic cause of hypoxemia. Lower normal AAO2 gradients occur with uniform distribution of ventilation. Elevated AAO2 gradients occur with non-uniform distribution of ventilation and with right to left shunts. Improving alveolar ventilation in a healthy lung region does not improve hypoxia due to regional decreased VQ. Increasing FiO2 does increase PO2 due to regional or global VQ. Hypoxia due to right to left shunt does not improve with supplemental oxygen. Wasted ventilation in parallel does not affect PCO2 or PO2, but wasted ventilation in series does. So next time, we will deal with gas exchange and VQ part 3. Thanks again to our producer director, Katie Lewinter. Thank you so much.